Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by SurvivingBreastCancer.org. I am Laura Carfing, breast cancer survivor and founder of SurvivingBreastCancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Our podcasts are made possible thanks to our sponsor, Store My Tumor. Your preserved tumor contains the most important information about your cancer. Store My Tumor provides live tumor preservation and coordination of advanced diagnostics and personalized immunotherapies. Thank you so much for supporting us. Hello, my friends. I'm so happy to be connecting with you this week on Breast Cancer Conversations. I'm your host, Laura Carfing, and if you're joining us for the first time, be sure to subscribe to our podcast and receive notifications each time we come out with a new episode. To all of you who tune in every week, welcome back. I'm so glad you're here.
Molecular breast imaging is a little bit different. We acquire the images in the same plane, so in the horizontal plane and at a 45 degree. Molecular breast imaging, the way that this works is we inject you with a radioactive material called technetium. The detectors that we use are much better than the way they used to be, and that's really why this is such a great modality. The most important thing is to just get this information out to everybody.
Welcome to the conversation. I have two guests here tonight for my listeners. I'm so excited that you guys are joining us today. We have Leslie Yerger, and you are calling in from the Chicagoland area?
That's right.
Excellent. So glad to have you. And you have a great story because we overlapped through our breast cancer diagnoses, and I think immediately, like, you submitted a blog for us and you were telling us how you walked 500 miles and what you were raising money for. And so I'm going to kind of leave the cliffhanger there for our listeners, and they'll have to kind of stay tuned to hear a little bit more about that. And you spearheaded this partnership and collaboration that we are able to bring Dr. Ha on the show today as well, which I'm also very excited to have because, you know, as SurvivingBreastCancer.org, as a nonprofit, as we are growing, we definitely rely on our community members to say, hey, here's a great topic, or here's something that I'm interested in knowing more about, or here's something I think we need to push out to the community, and how we can use our own networks to kind of bring in these amazing guests onto our show. So Dr. Ha, I'm very grateful and thankful that you have the time to spend with our community today. So thank you for joining us as well.
Well, thanks for having me.
Yes, and you are calling in from New York, correct?
Correct. I am actually the Director of Radiology and Women's Imaging at Mercy Medical Center in Rockville Center, New York. We are in Nassau County. Our hospital is part of a larger network. We're part of the Catholic Health System of Long Island. Currently, I am running a molecular breast imaging program. We are the only molecular breast imaging program in New York State.
Leslie, I would love for you to kind of take us back to maybe a little bit of how you and I overlapped in the blog that you shared, because if you are listening to our podcast and haven't checked out our website, we do publish blogs every week, and sometimes there are blogs that I write as well as blogs that our contributors from our community submit as well. So it's a really great way to give people kind of that overarching view of like, what is breast cancer, right? We know that no one's diagnosis is exactly the same, and same with people's experiences. So I love being able to represent kind of that gamut.
So it was back in November 2017, and I was doing just, regular healthcare checkup things. And one of the things that my doctor suggested that I do is to get a baseline bone density scan, since I was newly postmenopausal, just to sort of check, have something to check against and see if you're losing bone, later on in your life. If you don't have a baseline, then there's really no way to know. So that came back with suspicious things in it. And mind you, just a couple months before that, I had a mammogram and an ultrasound that came back all clear, fine,
Wow.
And so we began to investigate what was happening in the bones, and got to the stage of a bone biopsy and found out that it was stage 4 lobular breast cancer. And so lobular's a sneaky type of breast cancer, and that it's harder to see in the technologies that we're currently using. And so you can understand how confusing that was to get that diagnosis. And so I went to the Mayo Clinic for a second opinion, and the diagnosis was certainly confirmed. But through my time at the Mayo Clinic, I began to learn about this new breast cancer screening called molecular breast imaging that finds many, many more breast cancers in women with dense breasts, which I have. So I became interested in that technology and hoping to get the word out to more people about it, since there's a good chance it could have found mine if had it been available. There's no way to know that for sure. But what I do know is that there are a fair amount of breast cancers not being found right now through the technologies that we're currently using as standard. And so that's kind of become the job that I've given myself as a way to give back to
Absolutely.
other people.
Wonderful. Well, thank you for sharing that story.
Sure.
And I'm just curious if you don't mind sharing. I think when we think about different diagnostics, I don't necessarily associate a bone density scan with finding cancer, right? Like, that's not
Right.
necessarily one of the normal modalities. And I hear these stories a lot where people are going in for one ailment, they get a CT scan or they get an x ray and something looks suspicious, and then immediately it escalates into something else. Um, my experience prior to breast cancer has been like just going for like routine 1 year checkups. I never broken a bone. I never had any problems. I consider myself very healthy. So the more that I'm talking and hearing women's stories about how they're discovering their cancers and discovering it at a very late stage as well, um, is very shocking. And so, I every time I go to the doctors now too, or someone's telling me, "Oh, don't worry, I'm just going in for X, Y, and Z test," my heart immediately skips a beat because we're discovering things all the time about our bodies. Can I also ask, when they did the bone biopsy, did they know right away that it was breast cancer?
No, not at all. It actually looked like multiple myeloma in the CT scan and the X-ray. So that's kind of what we were fishing for. Even though there was a blood test and a urine test that came back negative. So we were everybody was kind of confused as to what it was at that point. So no, we didn't particularly weren't looking for breast cancer, especially since, I just had a mammogram and an ultrasound and that came back fine. And so, I don't know if my story is, a common story, but there are cancers that are being found later than they should be. So even a stage 1 or 0 is better than a 3, right? Regardless of whether you got to 4 or not, like I did. So I think that's really the bigger story here is hopefully there are ways that we can move to that we can find breast cancers a lot earlier than we are now. And
Exactly.
so that's kind of what I've dedicated my working life to now.
Wonderful. Well, thank you.
Mhm.
So I would love to just like jump right in. I think we have, two great survivors here on the call with very different experiences of how they found their diagnosis, myself and you, Leslie. And Dr. Ha, without just jumping right into like the fun and exciting question of what is molecular breast imaging, I would like to kind of give our listeners an overview of how complex radiology actually is in terms of breast health. I'm still learning myself too, without like the medical background. I go in and I have a mammography screening, and it really took me a long time to understand what the standard of care is versus going in for a diagnostic. So, because of my age, when I pushed my primary care doctor to write a prescription for me to be able to go and get a mammogram at 34, they did all sorts of pictures, right, in different angles, and I think a lot more than just, like 2 on each side or 4 on each side or whatever the hospital's practice typically is. So I'm going around talking about all these images that I'm getting, thinking that's normal, not understanding that this was above and beyond because it was a diagnostic process, and it quickly moved to an ultrasound as well because of the dense tissue. And such as like one example, I know in our breast cancer community as well, we talk a lot about, being able to advocate for 3D mammography or contrast enhanced mammography, MRIs. So within the field of radiology, there's so many options and technologies available. I would love to hear your opinion on, just a big picture overview of all of these options and then utilizing that maybe as an introduction for molecular breast imaging.
Okay, so kind of what you alluded to, there's two different types of mammograms, right? There is a screening mammogram, and the way that we screen is you get two views of each breast, all right? And that was really just basically, that was all we did for screening. But recently, with all the literature that's coming out about dense breasts, we've quickly realized that just the 2 views of each breast is not sufficient for screening everybody, right? So we are really quickly learning that we should be moving toward customized screening programs. And that's actually what we've done at Mercy. That's the program that we've developed, right? So what happens is when you come in, and you have no complaints whatsoever, right? This is for people who have no complaints and we're just looking for breast cancer to see if anything is popping up. The first thing that'll happen is we have you answer these questions, and everybody hates answering the questions because they're like, why are you being so nosy? But there actually is a reason, because what I do with those questions, and I look at every single questionnaire, we input the questionnaires into a program that will calculate what your 5-year risk is and what your lifetime risk of developing breast cancer is. Okay, so that's the first part. That's the first thing. As soon as you walk in, that's what we're doing. And then the next thing that happens is we take the pictures, right? We take the basic pictures. Once those basic pictures are taken, we actually have a software called Volpara. And Volpara, what Volpara does is it will measure what your breast density is. So it's not me looking at the picture and saying, oh, I think this one looks dense, or oh, I think this one looks fatty. It actually measures percentage-wise what your breast density is. And that's really important, because that means that's something that's replicable. And whether I do it or somebody else does it, like, that density is pretty much going to be the density that you have, right? So once I determine that you have dense breasts, yes, I'm still screening you, right? But now you become a dense breast screening for me, okay? And then what that means is we will do your 4 views, but I will also let you know, listen, you have dense breasts, and this study alone may not be sufficient. We need to have some kind of supplemental screening for you in the form of ultrasound most commonly, but because we have molecular breast imaging, that's another layer. So you should have your screening mammogram plus an ultrasound or molecular breast imaging. Okay, so that's basically the screening program that we have. Let's say that you also have a high risk for developing breast cancer because you've had multiple biopsies, or there's things that are involved that you're like, how does that have anything to do with what my risk would be? But it matters. When you got your period, when you had your first child, it's all these things that, family history, right? First degree relatives or more distant relatives, history of certain GYN cancers. So we look at all of those things. And if you have an increased risk as well as having the dense breast, I may recommend at that point that you add a layer of more protection and possibly get an MRI as well as an MBI. All right, so that's where, so that's really the basics. One of the questions I often get asked is, well, when should I start screening for breast cancer? And that's really important also. So right now, there's a lot of controversy as to what the starting age should be. But because I'm a radiologist, we go by what the American College of Radiology recommend, and that's age 40.
Okay.
With the understanding that if you have a strong family history, or if you have a first degree relative who has breast cancer, all right, we like to start screening you 10 years prior to the time that they were diagnosed, with the understanding that we won't screen you before you're like 25.
Okay.
Okay, so that's really an important bit of information, right? Because everybody, a lot of people say, well, I'm only 32 or I'm only 35, and they don't think that I should be screened for breast cancer. But we find out that, you had a sister who was diagnosed when she was 40. Okay, so technically we could have started screening you at 30, or if you had a mother who was diagnosed at age 45. Okay, so those are all little things. So that's step one. Step one is figuring out what your screening program is going to be and when we're going to start screening you. And then we have all these tools that we can use to figure out how we're going to screen you. And what you were saying is, so molecular breast imaging is yet just another tool. It's the latest thing that we have. We're the only ones in New York who have it. The unit that we have was supposed to go to Johns Hopkins, actually, and somehow we wound up getting it because there was like a little glitch there, I guess. The nice thing about molecular breast imaging really is that if your molecular breast imaging is negative, so there's nothing on the molecular breast imaging, there's like a 99.6 or 7% chance that you do not have breast cancer at the time that we're imaging you.
Wow.
So more than anything, I feel like that is really like such a relief for so many people so many women, especially when they have dense breasts, especially when we know that you have like a gazillion cysts and, little complex cysts and ducts and things like that. But, when you get that negative MBI, we can say, you know what, these things are probably all benign. There's a greater than 99% chance that you're good.
That's incredible. So,
Yeah.
if I'm understanding this correctly, would that actually decrease the number of biopsies then that you would need to perform?
Yes. So it could potentially decrease the number of unnecessary biopsies that you would need.
Excellent. For me, that was
I
like the
have a
most
question
painful part.
for Dr. Ha on
Yes.
that.
hmm
Other modalities like the other ones that you mentioned, ultrasound or something. Um, if those come back negative, then what are the chances that you would not have breast or that you would have breast cancer? Does that, you know what I'm saying? What's the same reference?
If you have a negative, you mean if you have a negative mammogram?
If you have a
Okay,
negative
so all right, so let's put it this
or
way. All right.
ultrasound
I
or
have some interesting numbers, okay?
okay.
So let's say that I screen 1,000 women, all right, and I use what they were supposed to use, the mammogram, but we're not even using the 2D, 3D combo, not the tomo, but the regular mammogram, right? If you use a regular mammogram, we will find about 3 breast cancers per 1,000 women on average,
Okay.
okay? When we add the tomo, the 2D, 3D to it, we add about 1.2 more people. So a little more than 4 people per 1,000 now.
Okay.
Okay. So when we add molecular breast imaging, we add approximately 8 to 9 more women per 1,000. All
Wow.
right. So we started off with 3, and if you want to add 8 or 9 to that, right, that's actually almost a 400% increase in the detection rate, right?
Yeah.
Ultrasound alone, so if we do the mammogram plus the ultrasound, we will add 3.2 more. So instead of having 3, we'll get about 6 per 1,000.
Okay.
All right.
hmm
So I don't know if that's useful information. I think it is useful information.
Yeah, it's
If we
significant.
do an MRI, we actually get more, believe it or not. So I don't want to knock MRI. We do an MRI, there's almost 15 more that we're going to get, as
Okay.
opposed to the 8 or 9. But why don't we just do MRI on everybody, right? At that point. Well, it turns out that with the MRI, all the ones that we're going to be biopsying because we think these things are positive, right? The false positive rate. So there's almost a 25% chance that the one that we're going to do is not breast cancer.
Okay.
Whereas with MBI, there is about a 6.5 to 8% chance that it's not going to be cancer. So much, much less.
Okay.
All right.
Thank you. That makes sense.
Mm-hmm.
Yeah. I do think those are
And
very significant
Yeah, and also
numbers.
your story was interesting that you said that you had the lobular, right? So
Yeah.
when we first got this machine a few years ago, one of my first patients that I had, I worked very closely with several of the breast surgeons, and he called me. He said, "I want to send somebody over to your office." He's like, "Can you see her, and can you do that MBI thing that you just got?" And I was like, "Yeah, we can, get ready." I said, "We'll schedule her for doing this." And basically, her complaint was that she felt that she had heaviness in one breast. One breast felt heavier than the other. And she went to several other, radiology centers, and basically she had mammograms and they told her everything was fine,
hmm
right? And
hmm
she was convinced that she had something. So she went to the breast surgeon and he said, "You know what?" She's right. He goes, "One breast feels heavier than the other." And maybe it's just that it's asymmetric, but he said, and it looks like there's just more tissue on one side, maybe. He said, "Could you do this thing?" We did it. That entire breast was so hot,
Yeah.
and when we saw that, I said, "Let's now go back and review the mammogram and do a targeted ultrasound of the area that looks hot, but it's the whole breast pretty much, right?"
Wow.
And when we did it, I said, "It's not a mass, it's just a shadowy area. It's like these shadowy areas." And I said, "Okay, we're going to biopsy these shadowy areas." And it became invasive lobular.
Right. Yeah.
So,
And can you explain to the people listening why lobular would show up on an MBI and not an ultrasound or a mammogram?
right, lobular is very tricky, as you alluded to,
Yes.
because lobular grows in sheets. Okay, so when we do a mammogram, right, we're looking at something in one plane, We look at it like straight on, and then we look at it at an angle, right? So because it's growing in sheets, if you're catching it in the if like in the plane that it's growing in, right? It's
Mhm.
going to look like a thin nothing. You're not going to see it. It's only when you tilt it and put it into certain planes
Mm.
that you may see something. And because we're radiologists, we always think you have to see it in two planes to actually think that it's real.
Mm.
So that's what you want. You want to see things in two planes, right?
Mhm.
But lobular is the one that, is tricky like that.
Right. Right.
What percentage, I'm not sure if you know this information, I don't mean to catch you off guard either. Do you know what percentage of women, either you, Dr. Ha, or Leslie, have lobular breast cancer?
I don't know offhand. It's not one of the more common forms, though.
Right.
I'm going to say I've read 10% and I've read 10 to 15%. So I think it's
All
somewhere
right.
in there. Um, yeah, the ductal is certainly much.
Right. That's the
That's the one that forms a lump, and that's what we are told to feel for. When we talk about these, manual exams or self-exam. Yeah, but lobular does not form a lump usually.
Yeah, usually it doesn't.
Yes, you have to really know what you're doing in order to be able to feel it.
Hmm. And it's also amazing to me how many times, I give talks at the local high schools, and you ask women, it's like, do you do your self-exam? And they're basically like, yeah, we kind of do it, but we don't know. It's like nobody's ever gone over it with us to see what it is exactly that we're feeling for.
Mhm.
So I do a little thing where I let them feel the tip of their nose, and then I let them feel like the little clavicle bone here. And I say things that are fixed, like this clavicle bone here. It doesn't move, right? And it feels very hard, as opposed to like the tip of your nose that feels a little rubbery. The rubbery things usually are okay. It's when you start feeling things that are hard and that they kind of don't want to move, and you can't move them around. That's really when you have to be more worried. And they said, wow, they said, we've never heard that. And, then you hear about like, oh, you should be going in a circle to figure out, feel every piece. I don't believe in that either. I think that the whole idea is to make sure that you're palpating the entire breast. And if it means that you're going up and down and sideways to sideways, could do it in the shower, use soap so that it's a little slippery so you really actually can feel things. The most important thing is that you do it on a regular basis so that you will be able to detect any interval change.
Right.
So you really have a good idea of what your breast feels like. I think I jumped the gun a little bit. So I actually, maybe people may not know what molecular breast imaging actually is, right? So most people know what a mammogram is, right? So a mammogram, it's an X-ray. It's an X-ray of your breast, and the way that we acquire these images are, we squeeze the breast along the horizon, so from top to bottom, all right. And it's a pretty decent compression. It's about 20 pounds or so, and people don't like it, right? And then we take the X-ray and we look at those images, and then we also take another one called an medial lateral oblique, which is at a 45-degree angle, and it's compressed this way, and we take those images. And again, it's an X-ray. Molecular breast imaging is a little bit different. We acquire the images in the same plane, so in the horizontal plane and at a 45 degree. Molecular breast imaging, the way that this works is we inject you with a radioactive material called technetium. And as soon as I say that, people kind of freak out a little bit. They say, "Oh my God, you're injecting me with radiation." But the fact is that it's a very, very low dose. It's extremely safe. The dose that we use is the same dose that you get for if you were to have a cardiac stress test, right? But it's the resting portion of it, which is like the first portion, very, very small dose. Um, if you want to have an idea of what exactly is this amount of radiation, it is the background radiation of living in most parts of the United States for the course of an entire year. So it's not that much. It's very small. That if I were sitting next to you right now, right, you would be receiving radiation from me. People don't realize that, but that's the way it is, right? So it's just like it's a 1 year's worth of background radiation. It's very small. Um, and in terms of the safety of technetium, it's been around forever. It's what we use for cardiac stress tests. We inject it and then it goes away. You basically pass it out of your body. It's not something that stays in there. The detectors that we use are much better than the way they used to be. And that's really why this is such a great modality now. In the past, the detectors weren't so sensitive, so you would have to use so much technetium that it really, outweigh the benefits. And now we can use a very small dose because the detectors are so much better. And, they're always working on improving even more.
And what exactly
And that
are they detecting? Is it like the activity of the cells or the heat, or what's the?
it's actually gamma rays, believe it or not.
Okay.
It's a gamma camera, so what it does is things that are active, tissues that's active, tissue that's dividing more rapidly, like cancer, right, will take up the radioactive material more than the regular normal tissue. And that's how we are able to detect what area is hotter, let's say, right? But the problem is that women who are premenopausal women, depending on where they are in their cycle, can have active tissue. And that because we've all experienced it, right? We all know we all knew when we were going to get our periods because everybody was knocking into our breast because they were engorged and they were sensitive. So same thing. So we try not to image you during that period. We try to image you when your breast is a little quieter. If you're postmenopausal, it's not an issue.
Wonderful.
Can you explain what it's like to get the test?
So the way that we do it is you come into a room and we sit you in a chair. If you want to stand, you can. And basically, as I said, it's light compression, okay? It's about 10 pounds of compression. And it really is just compression to hold the breast in place so that it doesn't slip around, that we can acquire these images. And it takes about 7 minutes per image. So we do 2 cc's and 2 mLOs, so that's about 28 minutes. Oftentimes we'll give you a warm blanket so that it will help the circulation. It helps, you may get some aromatherapy, and basically we'll put you in there with 2 televisions so you could watch the HSN network while you're getting your study. And then that's really pretty much it. It's pretty easy. When you come in, obviously we will inject you with this, the technician with tiny little needle.
Okay.
Mm-hmm. And that was your experience?
I never got one.
Oh, you never got one. Okay.
No, I went to the Mayo Clinic and, well, we were already on the,
Right. You were, yeah.
track. So
Right. Yeah.
I wasn't in a screening program there. It was more for
Right.
just
You were already there for you were diagnosed. Yeah.
Yeah.
Mhm.
And so that's why I was interested to ask you that because,
Anytime you want to come and visit us,
oh yeah,
you're more than welcome. I'd like to show it to you.
yeah, that would
Yeah.
be great.
Mhm.
Yeah. Nice.
Yeah, and I haven't heard of this until Leslie, you started telling me all about it. And I was like, oh my gosh, there's like more technology and so much to keep up on. So this is really great to be able to kind of take a deeper dive into exactly what the MBI is and what people can expect when they're going through a screening. You mentioned that your clinic is the only one in the state of New York that offers this type of screening and this type of study for people. How widespread, or I guess in this case, like not widespread, is this technology?
There really aren't that many units. I think that there are maybe 50 units throughout the country right now or something like that, maybe less. We run into several little hiccups, so to speak. The main issue being that the insurance companies don't want to reimburse it. They will reimburse, and there are certain insurance companies that actually always reimburse. And, we keep a little chart together of who are the ones who always say yes and who are the ones who almost always say no. If you have Medicare automatically, everybody gets approved. A lot of these other places, they'll approve you if you have the doctor call in. But that can be a problem because, you have to call, they put you on the phone and you're literally on hold for about half an hour. And so, there's really just isn't enough manpower to do that, I guess. We have we have a good program because we work with the surgeon and he actually has a navigator who gets on the phone and will say, this is Dr. So-and-so's office, and she'll stay on hold until somebody comes, at which point he'll stop doing what he's doing and he gets on the phone and he tells them what's going on. And we're very good at getting the approval.
Yeah.
So
that's really good. I remember the first time that, knock on wood, first and only time that I got a letter from my insurance company telling me I was not approved for a particular chemotherapy drug. And I was livid because, you put so much trust in your oncology team that, this is going to be part of like that plan. And I remember going in for my like weekly checkups, and I brought in my paperwork, and he's like, "Oh, don't worry, we called them. It's taken care of. You can ignore that letter." But you're right. There's a lot of behind the scenes administrative, back and forth and man hours that you're mentioning that go
Mm-hmm.
into a lot of this treatment and access with regards to where this technology is, and then also access in terms of finance.
Right. So I think so. Insurance certainly is one of the main issues that we have, but I think that it's even more multifaceted in some ways of why this technology isn't being adopted so quickly. If you think about it, I think part of it, it's everybody has a little role to play. Let's say, from the radiology point of view, this is the people who are doing the mammograms. Usually, all they do is mammogram. I'm a little bit different because I do other modalities. I actually do neuroradiology also, which means that I'm very comfortable looking at CTs and at MRIs, and I like doing other modalities. So I do the mammograms, I do the breast MRs, I do ultrasound. And when this came up, I said, sure, it's like I can definitely do this. But they were like, but it's nuclear medicine, and people who do mammo don't want to learn not only a new modality, but it's a completely new type of imaging. It's not like a different type of X-ray. It's a completely different, you know, modality, right? It's not like it's an X-ray and we're doing a different type of view.
Right.
So I think that really, it's hard. It's going to take a lot of education to let people know, yes, this is a nuclear medicine study, but really it's breast imaging.
Mm-hmm.
So don't think of it as a different modality. Think of it as a multi-modality approach to a certain problem. And the problem is breast cancer screening.
Yes, I love that multimodality. I use interdisciplinary all the time, but I'm going to start using multimodality. That's a
Yeah.
great one.
Yeah. So I think that's the best. We have to use every tool that we have.
Yes.
Um,
So, Leslie, I don't know if you've had this experience, and I know that there's a lot of legislation still trying to get passed to require various states in the United States to give women a letter if they do have dense tissue. And, it still blows my mind that this isn't like a requirement across all of the states. But I know in terms of like the advocacy sector for breast cancer, there's a lot of momentum to try and get this law passed in all 50 states. I think last time I was reading a statistic, it was at 38. I don't know since like the last couple of months if it went up. Hopefully it did. But about 38 states from the last time I was reading about it were required by law for the radiologist team to give some sort of letter and notify the patient that they have dense tissue. What continues to baffle me, and again, an area for advocacy that we're trying to just make aware and act on, is that there's not a standard either of what degree this letter has to inform the patient about what their options are, right? So you can have some states that say you have dense tissue and here are the things that you should do next or what you should take into consideration. And then there's some states that literally just give you a letter and, it could be very vague and there's no direction or like follow up. It's really just, this is my requirement. Here's your letter. I'll see you next year. Can you speak a little bit about, like, I just feel like talking about dense tissue in general is such a, I mean, we could talk for hours about it. I think it's very complex, and the more that I'm speaking with women who've been diagnosed and with radiologists and my own understanding and research, I'm trying to make sense of all of the statistics out there, and we advocate for early screening and early detection. And someone brought to my attention that, the mammography in its traditional sense of just like, the traditional mammogram is only as good as like a percentage of how dense your tissue is.
Yes.
And so I would love for you to like elaborate a little bit on that because, well, I said this right now to talk to you about it. It's very, it's complex, right, to understand these ratios. And, you go in for your mammograms. And Leslie, in your point, like a couple months ago prior, you had clear mammograms. So, it's unsettling.
So let me see. I don't know if this is going to project for you, but let me actually do a little talk and let me see if I can show you this. So basically, can you see this? I took this from Wendy.
Yes.
It's Wendy Berg's image, right? Basically, so you can see that the one over here, this is a fatty breast, okay? And you see how it's very dark? And this one is a dense breast, okay? So the difference is the denser you are, the wider the breast gets, right? Well, it turns out that breast cancer is white, right? So if you're looking for something that's white in a background that's completely white, you can imagine that this is a very challenging task. right? Whereas if something is basically dark and you're looking for something white, that's much easier, right? So
Mm.
that's the first point. The other point is if you think about this at the most basic level, right? Your breast is basically made of fatty tissue and glandular tissue because it's an organ that makes milk. So there's going to be a portion of it that's fatty, and then there's a portion that makes the milk, the glandular tissue. Well, it turns out breast cancer is not going to, you're not going to get a fatty breast cancer, right? The fat's not going to convert into some kind of a tumor. Like it can, there's like liposarcomas and things like that. But we were talking about breast cancer. So these are things that are really arising from the glandular elements. So if you have more glandular element, you actually are going to have an increased risk because there's more of it,
Mm.
right? That's really at the most basic level. Um, and this is really with that realization, I think this is when everybody said we have to have supplement. This just doing a mammogram alone is not sufficient. We must have supplemental screening. So it's not a diagnostic test at that point. It's an added layer of screening. So people who have dense breast should have this added layer of screening. And then in terms of detection of cancers as the density increases, this is part of the studies that Volpara has done, the Volpara people,
Mm.
right? When they looked at it, they said that, when the breast tissue is fatty or scattered fibroglandular, the detection rate's pretty good, but somewhere in the middle of the heterogeneously dense group, right? So they're like greater than 50, less than 75%, that area, it's when it's really in there somewhere that the in terms of the consistency of picking up small lesions really drops off because we just can't see it,
Sure.
you know. So in some ways you think about it, yes, it's a seeing eye test, but should it really be a seeing eye test? It shouldn't be, right? That's really not fair, and that's really why MBI is so great. I have a great story for you. So we had a woman who came in. She was seen outside. Sh Her dermatologist saw her and she saw a lump. And she said, "Oh, did you know you had this lump?" She said, "No, I didn't notice I had this lump. What is this lump?" So then they examined her and she had a lump in her armpit also. So they said, "Oh, that's really weird. You have a lump in your armpit. You have something like over here." So they wound up biopsying the lump in her armpit and it came back metastatic cancer, probably breast. Well, she had just had her mammogram a few months ago, right?
Wow.
And she had fatty breasts. How about that?
Wow.
So they
Mm.
said, okay, this is really crazy, right? They said, how could she have breast cancer? And she had mammograms for over 5 years beyond that, that the mammogram hadn't changed. They brought me the mammograms. I look at them, they were not changed. It's not like we missed anything. Nobody missed anything. There was nothing there pretty much. It had not changed. So the surgeon called me and said, oh, I saw you did a talk. Do you think that, this MBI could help you because we have this metastatic breast cancer and a fatty breast and we have no idea where this is coming from? I said, sure. But I said, maybe we'll try it. But she also said, oh, by the way, she goes, she had a PET scan that only was hot in the armpit, nothing in the breast showed up. So I said, oh, well, we could still do it because the PET scan's a big body scan and this is really a targeted study for your breast. So sure enough, we do the study and there's a tiny little area that's hot. I mean, it's a little specky area that's hot on the MBI, but it happened to be in the breast that had the lymph node.
Mm.
Okay, so now we have to go back and look at the mammogram, do a targeted ultrasound of the area, and the only thing that I can find is she has this small cluster of calcifications that hasn't changed in 5 years.
Wow.
Who biopsies things like that? You don't. So I said, well, you know what? I said, this is all I see here. Maybe we should biopsy this. And she said, absolutely. We biopsied. That was her primary.
Wow.
Primary. Yep. And it had already gone to her lymph node. So it was a tiny little cluster. Hard to believe, right? But that's where MBI, not only just for screening things, but it really is a powerful adjunct to diagnosing. It's a powerful tool that we can use to help us diagnose and to problem solve difficult cases. I think that's really my favorite way to use it. So,
Yeah, it's almost like finding like the scavenger hunt backwards, right? Like
yes,
you've seen like
exactly.
the advanced stage and trying to figure
Hmm.
out its origin.
Yes.
I am definitely going to recommend you and MBI to a really good dear friend of mine who unfortunately also got diagnosed at stage 4.
Hmm.
And to this date, it has not been traced back to her breast. she ended up keeping her breast. She didn't, because she was already metastatic.
Okay.
I think with all of her screenings and mammography scans and CAT scans, PET scans, etc., to date, from my understanding, is that there is just no, it's not in her breast. It's pretty much everywhere else in her body, unfortunately. And so that would be very interesting, I think, from,
That would actually be a really interesting case.
yeah,
Yeah, absolutely. So she's still metastatic,
yes,
but they don't have a primary on her, but it's
correct,
breast for
yes.
sure.
And Leslie, that's why I was asking you some of those questions too, like when they did the bone biopsy, because for this particular woman too, it was very similar. They did a bone biopsy,
Mhm.
and they didn't know what it was. They were like, well, and she was, what type of news is that, right?
Right.
You're worried, and then your doctors are like, well, we don't know, and you start to realize that medicine's not a perfect science, and then it's all of these like investigative, trying to find what is it. So
Right.
I can empathize with that experience that you went through as well. With, is it one thing, is it another thing? You do all these tests, and you're just kind of waiting to try and get
Yeah,
some clarity.
it's a harrowing experience, to have it that way. But something that Dr. Ha alluded to a couple of minutes ago, I've had this thought for a while that it feels like to me really tough on the radiologist to have to find things in a pictures that are just all cloudy. Like that seems seems unfair to me almost to expect them to see something that's not really seeable.
That's why I said it. I don't think that this should have to be a seeing eye test, on many levels, but it is, you know what I'm saying?
Yeah.
And from my point of view, this is my job. Okay. My only job is to find breast cancer. When I'm looking at these mammograms, when I'm looking at breast, my only job is to find breast cancer.
Right.
And if it means that I'm whatever I need to do. So that's really why, like, I feel like I need to know what's your history. I need to know, if I see that you have a very high risk, right, and I just don't see anything, and I'm sure that, I feel like you're going to get breast cancer at some point. You can bet but that I'm gonna do everything that I need to do to make sure that it's not there when I look, and that if it pops up between the time that I see you today and the next time that you come, that I'm going to catch it at the earliest point. I mean, this is the best that we can do, but I have an extra toy that nobody else has, and I use it,
Yeah,
um,
absolutely.
and it helps me. So I think that when people see that it really is helpful when we get this information out to people, um, when doctors see how helpful it is, when patients realize that there's something else that they can use, and they basically say, listen, I want this test. I think that, with education, we will get better.
Right. So my experience has been so far, because some people know about it because I took this walk to raise
Hmm.
money for the density matter study at the Mayo Clinic, et cetera. And so they know my story and they'll ask their doctor, what about this molecular breast imaging test? Because I have dense breasts.
Hmm.
And usually the response is, oh, I've never heard of that.
Correct.
Hmm.
So then what can the woman say? Is there,
Well,
like, how do we then move on from that?
mhm. Okay, so basically, one of the things that you could do is there is a website that I think has a list of all of the centers that are currently have molecular breast imaging.
Okay.
All right, so you can look at that website and say, listen, in my state, I see that this is where it is, and say this is where I want to go. At our hospital, the patients can actually pay out of pocket if they want.
Okay.
And what we've done is we basically bare bones, as low as we can go, as low as I can get the administration to agree to, and that's what it is. That's what we charge.
Okay.
Um, I think that it's reasonable. It's a significantly less than getting an MRI. Most people can afford it. I have other things that are available to me that if you really are somebody who needs it, who doesn't have it, I have grants that will cover you and things like that. So
Okay.
that's how we do it here. But I think that really and it's terrible, but the onus is on the patient that if you know that you want this thing, you have to push. And if your doctor doesn't know about it, you know what? Call them out on it and say, listen, I need you to research this and I want to get this done. I think the main thing is, if you push and say, listen, I would like to get this done, and if you don't have this available, I'm going to take my things and I'm going to go where they have it.
Right.
It's always about hitting people in the pocket.
Right.
It's terrible, but I think that really does, drive a lot of things. I think that's one of the reasons why, everybody likes doing MRI, right?
Hmm.
An MRI on average, I think the Medicare reimbursement rate for an MRI is like over $1,000. The MBI, I think, reimburses at about $400. So if you're an institution, I think that you'd much rather do the thousand. I mean, this sounds terrible, and I don't know that this is true, but you can kind of read between the lines, I guess. If you can get paid $1,000 for something as opposed to $400, which one are you going to do?
Sure.
And it's certainly, especially since the $1,000 thing is the one that gets reimbursed. All
Right.
the insurance companies are agreeing to pay for that,
Yes.
right?
Question about that though, is that not only is that not just for the highest risk people?
The MRI, it
Right.
is. It is for the highest risk people.
Okay.
Yeah,
So
I
those
think. Yeah,
people,
I like to use it sparingly.
yeah. So I'll take myself as an example.
Hmm.
I never qualified. I would never have qualified for an MRI.
Correct. You would have had to pay out of pocket for
High
that.
enough risk.
Hmm.
Um, and isn't that true of over half of the breast cancers anyway? Is that,
Yeah,
absolutely,
absolutely.
about 75% or something?
Yeah, most breast cancers, you're the first one who has it. It's like, yes, if you have a family member who has breast cancer, you are more at risk, right? But by and large, most of the breast cancers that we detect are with no family history,
Yeah.
right?
Mm-hmm.
And I think the other really important thing that we kind of didn't discuss right now is we talked about your family history. We talked about that sheet that you have to fill out. We talked about your breast density. And I think that the next thing that I actually want to do that I think is very important is genomic testing, right? I think that genomic testing is going to become a really important thing. And what I'd really love to see is that when you come in, that basically you are offered genomic testing. You come for your mammo, and part of the screening should be that you should be screened genomic, your genes should be screened. And if you have like these variants or if you have these genes, right? Well, hello, we need to put you in a different category. We need to be a little more aggressive with you as
You're
well.
talking about BRCA.
Yes, but BRCA's just, one of the things. BRCA is the one that we all hear about, but there are so many others, and every day we're finding more and more things. I mean, they actually found that young women who develop breast cancer after pregnancy, right? There's actually a variant in the gene that, they're finding that more and more common with that. So if you know that you have that, maybe you need to be a little more careful, be very, yeah, if you have a kid, then you have that gene, then you really need to screen yourself carefully afterwards.
Wow.
Yeah.
Yeah.
There's a lot out there.
There is so much out there.
We
There's
just
so
have
much information. It's really hard to keep up.
Yeah.
It
Yeah,
is.
we just have to get it out there and get it
Yes.
used by everybody in the population to
Yeah.
really make a dent in what's going on, right?
Right.
Yeah.
Exactly. And I think this information, like, I get goosebumps every time I have these podcasts and talk with amazing women like both of you because, like, you're always learning something new, and it takes time again and again and again to hear the same content. What I'm so excited about, related, unrelated, but just to share, one of our um, one of our colleagues I just did an interview with on just this topic of genomic studies and the whole discussion around, precision medicine and, genomic testing and trying to really figure out that like
Mhm.
specialized medicine or specialized screening as we started off this conversation was we are very individual and there's all of these factors that play into a potential outcome. So I think
Right.
that's just has to be stressed. I also want to stress to our listeners the importance that you've been stressing, Dr. Ha, of knowing your family history. I unfortunately found the category of not knowing my family history mainly because of it's not something my family talked about. It
Right.
was very close to the vest. It wasn't something people bragged about. It wasn't something we knew like aunts and uncles. It was like, we're good. Everything's good.
Mhm.
So when I moved to Boston and I had to find a new primary care, she's like, so what do you have in your family history? I'm like, I think I'm fine. Like, I don't know, maybe like high blood pressure, maybe, right?
Mhm. Yep.
And it wasn't until post diagnosis, my mom flies out from Chicago. We go meet with a genetics counselor, and oh my gosh, like the little gene tree of like what everybody
Right.
had was,
It's good. Yeah.
quite telling. But I think I share this story because I didn't know how important that piece was in the puzzle. I did not test positive for any of the 8 genes that I got screened for. So unfortunately, there's no family connection in that regard. So I was like, oh, good, that's great. I don't carry the gene, but wait, it's sporadic. And so, like, how did I get this? Um,
Sure.
so it's just, I want to let people know too, like, understanding that family health component can really make a difference, whether it's breast cancer or any sort of, disease and illness.
Right. Because there are other cancers that are associated with breast cancer. And again, I said, the time that you had your first period can affect your risk. The age of your first pregnancy can affect your risk.
Really?
People are, yeah,
Wow.
yeah,
The longer, the more risk.
over 30. If your first child is over 30, and I'm like, in this day and age, who has a kid before 30? I certainly didn't.
Yeah, I was 32. So.
Yeah,
Mhm.
yeah, crazy, right? So we ask you that question, and people get annoyed. Or not having children also increases your risk.
Well, that's me too. So wait, you either have children or you don't have children. There's a certain age window.
Yeah, did all these things
Oh my
all these things
gosh.
play a factor? And it's like we really aren't trying to be nosy. We're really trying to figure out what your risk is.
Right.
Right.
And finding the
Yeah,
patterns
I
with those
changed that. I
risks.
changed that questionnaire. It used to say breast history, and now I told them, I said, change this thing, and I make it really bold and big, and it says breast cancer risk assessment.
Mm.
You know,
Yeah.
so it's like, heads up, ladies. It's like, we're not being nosy.
Right. And is breast density part of that risk, or is that a
Yes,
separate?
breast density is part of the risk.
Okay.
Yes, that's why I said, when you come in, I look to see what your density is. I don't do it with my eyeballs. I do it with the machine. Volpara is excellent. All the studies on breast density, or many of the studies, have used that software in particular. Some of the other companies are, using different things, but that's the one we use. I really like it. And I'm not saying that because, I have no connection to them or anything like that. I just happen to think it's really a powerful tool.
Okay. Great.
Yeah.
Wonderful.
Yeah.
Another piece of information that I learned in my research was, how we define risk. I would love to pick your brain and, help myself and our listeners understand, what qualifies as high risk. I know we're talking about like potentially family history and all of this assessment that you're doing.
hmm
And I bring this up in the context of my own experience when I went for, post treatment, post breast cancer, annual screening, not a diagnostic. So that helped me understand, the difference in that type of screening. I was going in for a just a regular screening. And then I'm in Massachusetts and they give me that letter that says I have dense breast.
Press. Yeah.
And I'm like, okay, great. I got this letter. I'm empowered. I started a nonprofit. I'm running this podcast. Like, I know what to ask next, right? And I'm so excited to say, okay, I want like, whether it's the ultrasound, now I know to ask and investigate and learn about potentially the MBI. And the person I was speaking with told me that I was not high risk. And I was totally shocked to find out that someone with breast cancer is not at high risk for recurrence.
You are actually high risk.
Oh, am I?
Once you have a history of breast cancer, so there are certain things. So one of the things that I always look for is, you have women who come in and they've had biopsies, right? And I see, they've had biopsies, right? And then I'll say, oh, you had a biopsy, but that looks like there's a little scar tissue there. It looks like there's a little distortion here. And I'll say, like, did you ever have a surgical biopsy, like an excisional biopsy? Not a lumpectomy, an excisional biopsy, right? And they say, yes, I had an excisional biopsy. It's not cancer. Everything was fine. But then I'll go back and say, okay, so you actually had a needle biopsy. The needle biopsy must have shown something that said, hey, listen, you know what? It was either an intraductal papilloma, it was a radial scar, it could have been what we call ADH, atypical duct hyperplasia, or atypical lobular hyperplasia. If it's one of those two of the latter, if it's one of the atypical, lobular or ductal hyperplasia, that actually is a high risk lesion. Okay, intraductal papillomas, the jury's still thinking about, we're still thinking, like, we're not really sure yet, but I will tell you that if you have an intraductal papilloma, most surgeons will take them out.
Okay.
All right. An intraductal papilloma is like, it's like a wart in your duct.
Mm.
All right. It's like a wart. It's, papillomavirus, right? And even though that in itself isn't cancer, we're not sure if it predisposes you to cancer or if it's going to be in areas that may have cancer. So that's why we take those out. Um, so if I see that you had surgery after a biopsy, right, I always question you and I'll say specifically, did you have atypical duct hyperplasia or atypical lobular hyperplasia? Because if you have either one of those things, you are put into the high risk category right away.
Sure.
Okay. The other thing is once you have breast cancer, right, and you have a diagnosis of breast cancer, the protocol that I use is I want to see you back every 6 months for the side that has the breast cancer. Okay. And you're going to get a mammogram, an ultrasound, and whatever else I need to do to figure out what's going on with that breast. Okay. So you will have and you're diagnostic for 5 years. You have diagnostic imaging for 5 years after that, from the time that from the time that you have your surgery and that you're diagnosed. So you'll come in 6 months, I'll do the side that has the breast cancer or had the breast cancer. You'll come in another 6 months, I'll do that side and then we'll screen the other side. 6 months later, we'll do the side with the breast cancer, and this will go on for 5 years. Okay. Once you're clear for 5 years, now you get thrown back into Gen Pop, right? You're back to the screening program, but you are no longer a regular screening for the rest of your life because you had that breast cancer. In my book, you were always a high risk screening. Okay. So you will be a high risk screening for me for eternity. So anytime you come and I know that you had that history, you're a high risk screening and you're going to get extra. But I mean extra, not in terms of I'm not doing extra views on you, you know what I'm saying? But you're going to have extra layers so you're going to have supplemental screening, either in the form of mostly ultrasound or MBI.
Yes.
You know.
No, that makes sense. And is that particular to you and your practice and your screening after a diagnostic?
It's
Um,
actually a recommendation that's kind of like an ACR thing. I mean, that's really
oh,
a recommendation. They say you should, yeah,
that's really great to know. Again, another
yeah,
moment of
yeah. A
empowerment
lot,
of,
and many places do it that way.
I'm just curious why you think it is. As I do a lot of reading on the internet and what all these organizations recommend for supplemental screening and under what conditions. And first of all, I know that they differ in their recommendations. And then they almost always just mention ultrasound or MRI. And yet there's this other modality that is out there that's been FDA approved for a long time. And it confuses me. And I was so surprised to learn about it really just by accident at the Mayo Clinic. Like I said, we never had it. So I'm just curious about that. Why do you think that is?
I think it's nobody likes change. People are comfortable with what they're comfortable with. When you ask, it's really like part of it has to be that the radiologist who are doing the study has to say, hey, I need this thing. But if the radiologist is saying like, you know what I'm working with is enough, I don't really need anything new, then it's never going to be something that the hospital is going to be interested in purchasing. A lot of the clinicians are depending on what the doctor who's looking at the study is saying, this is what I need to make a diagnosis. And if they tell you, I'm doing the mammogram, I'm doing the ultrasound, it's good enough, then there's no information out there to say that there's something extra. So I guess a big portion of this is that we have to educate radiologists a little bit more to say, listen, we're not saying that what you're doing is insufficient. We're saying you're doing a good job. It's like we don't want people to think that, oh my gosh, you're not doing a good job. You're doing an excellent job. But hey, wouldn't it be so much better to have something to make that you could do an extra? You could do something extra.
Right. Right.
And I think that's really what it is. It's really all about education.
Okay. All right. And how does that happen? Like how do radiologists get educated on new things? How does that work?
I think what happens a lot of times is my experience has been, and what I've always advocated for is, the cases that nobody else wants to do, that it's just like, I don't know what to do with this case. It's like, let me do those cases for you, and if I can prove to you that this is working,
Mhm.
prove it to you once, okay, prove it to you twice, prove it to you 3 times. And at that point, maybe you'll say, you know what, I think there's something to this.
Right.
So it's a really slow procedure. It's a slow process, but we just have to keep at it.
Yeah.
There lots of things are like this.
Mhm.
You know, even in the course of my time as a radiologist, I remember there was a time when anybody who we thought they had a kidney stone, believe it or not, we would inject them with IV contrast and do what was called an IVP. Nobody even knows what that is anymore because we don't do it. You get a CAT scan, you see the stone, and you're done. But in order to get from that to getting a CT, it was insane. My nephew had it as a kid, had a renal stone, and they said, no, it can't be a renal stone. He's a kid. And I said, can you do the CT, And they said, no, we're not going to do it. Finally, they did it. They found the stone, but
Right.
only because I was the radiologist and, we insisted that this was done.
Right.
Now, this is what's done all the time. So change is really difficult and change is slow.
Right.
Mhm. Yeah.
Okay.
And you hear that with breast cancer too, right? Like, oh, it can't be breast cancer, you're too young, or,
Exactly.
you don't have a family history. And like, well, you don't need a family
Right.
history to have breast cancer. I mean,
Right.
again, it's just one of those other factors for the risk factor.
Women's imaging review course that the Mayo Clinic is putting on in, I think it's December.
December.
And they're
Yes.
having an MBI breakout session. So this is what we were just talking about, right?
Right.
This is how a radiologist, if they're at this event, could learn more about this modality at this breakout session.
Everybody's fascinated by it when they hear the lectures. I hope that a lot of people go to this. I'm certainly going to try to go there. I know it's a half day.
Yeah.
So I'm going to try to sneak out of Dodge and get over there.
And, just tell all your radiologist friends that this
Mhm.
is in Naples, Florida
Yes,
in December.
I know.
I
As matter,
mean,
the
what?
other we have one of the women that I work with, my other the other member. She's actually going to be there. She's going.
Okay, great,
Yeah.
great. Yeah. Yeah. So I think that's, one way that I know that doctors have, continuing education.
Uh-huh.
Not the word they use, I'm sure.
It
But
is.
yeah, okay.
It's
All right.
CME, Continuing Medical
There you
Education.
go. Right. All right, great.
Yeah.
I do have just a question for you, just in concise words. What is the recommendation that, Laura, I'm doing this really for your organization because everybody's a survivor or a thriver. So for your audience specifically, what would you recommend that they do in terms of screening for themselves, given the fact that they are survivors? What is the 2-sentence takeaway that they should take about their screening, given that they have had breast cancer before?
5 years out, you are a high risk screening.
Okay.
You're high risk screening. So mammogram, sonogram, MRI, or MBI.
Okay. All right. And some of that differentiating between those has to do with your density?
No, if you're high risk, I want to see you getting everything.
Yeah, everything. Okay.
Yeah, I want, maybe you can forego the sonogram because
Okay.
sometimes sono, with a fatty breast, sono is difficult to find things.
Okay.
Believe it or not, sono is not great for fatty breasts.
Hmm.
So I like to target. So if you have fatty
Interesting.
breasts, and if you have a fatty breast, instead of doing a ultrasound of the entire breast, I am much more likely to do a targeted ultrasound in any areas that may have areas of dense tissue rather than to screen the whole thing like that because it's really difficult. It's difficult. It's
Okay.
difficult, laborious for the techs, and you don't. Again, like I said, it's not a seeing eye test for me. We also don't want to. It's not a punishment for them that they're sitting there, you know, scanning through a triple D breast that's all fatty. They're not going to find anything unless I tell them, listen, I need you to go 5 o'clock. Go about two
Okay.
hands from the nipple, and you're going to just scan that area like crazy.
Okay. All right.
Yeah.
Okay, that's great to know because I'm not sure that that's widely known. What do you think, Laura? That
Yeah.
you are absolutely high risk after?
Yes. I mean, it's always in the back of our minds, right? And
Yeah,
I
it makes sense.
Oh,
Yes.
it completely does.
Yeah.
And
Yeah.
I'm so glad you asked this question because, there's good days and bad days, I think, for us, right? Where, we're grateful to be alive and we went through this vigorous treatment and we're here. And then there's some days where just even very recently, I'm going to be celebrating my 3-year survivorship, like in a couple of weeks. So from my date of diagnosis. And it's almost surreal that like I'm technically healthy. Like, we feel like we've been sick and going through treatment for so long that it's hard to embrace kind of this new like, no, it's okay. You really do just have allergies. It's not a symptom of cancer. Like, take some Claritin and you're going to be fine.
Right.
Or I had a tickle in my throat and I was like, oh my gosh, I think I need like a chest X-ray. Like something is just not right. And to your example, also, Dr. Ha, when you were talking, I'm sure everyone's situation is slightly different, of course, but if the breast cancer has traveled to one of the lymph nodes, um, I guess the terminology is a little confusing too, right? Like technically, it has metastasized outside of like the local breast area. It's been
Right.
to the lymph nodes, but it's not necessarily classified as stage 4, if I'm saying this correctly. And so what keeps me up at night is I'm going in for what's soon going to be my 6 months, every 6 months for 5 years screening. But what if they don't find it in my breast? Like, should we be advocating for CT scans or other type of screenings in the future outside of just waiting for a symptom or something not right to show up to say, no, I think I have bone pain in my femur, or I think I'm having like severe headaches. And then for them to all of a sudden, I feel like we're just waiting to be diagnosed with a later stage.
I think that some of the places, if they know that you have metastatic bone or you have metastatic disease, they will screen you. They'll screen you, I think, annually with a PET scan. I
Okay.
don't, that you could, so there are things that you can do. You can get a PET to make sure that there's nothing
Sure.
going on also. So that's another level of screening. One of the things I always tell my patients, and it's really getting a diagnosis of breast cancer is devastating, right? But, once you have your lumpectomy, once you go through your treatment and they come back for their 6 month, I tell them, I said, listen, I said, so you had breast cancer, right? And what that means is now you're going to come and see me for every 6 months. We're going to check you every 6 months. Think of it this way. Think of breast cancer as that's your disease. Okay. I could have told you that day that you had diabetes, right? And if you had said, I'm going to ignore it, I'm not going to check my diabetes, I'm not going to check my blood sugar, your blood sugar could go off the chart and you could wind up having to have like a toe cut off. People wind up having amputated legs, So if you think of it that way, those people have to check. How many times a day do you have to check your disease at that point? Multiple times, right? With the breast cancer, yes, this is your disease. You're going to check this and you're going to stay on top of it. My job is to make sure that you keep coming and that if anything happens, that I'm going to catch it for you. But I can't do it alone. It's like we are a team.
Yes.
We're a team.
Yeah, I love that. I love that. I'm smiling over here. I'm like, all right, we got
Yeah.
the team. We got like you're
Right.
advocating on one end, we're advocating on the other end. We're coming together. We're
Yes.
taking care of ourselves together.
Yep. We're women. We're strong. And I always tell them, I said, you could do this. I said, you can do this. Women are strong.
Wonderful.
Yeah, I agree with that.
If this podcast was helpful, be sure to subscribe, share with your friends, and leave a review so we know that you liked it. There are so many ways to join our community. Be sure to subscribe to our weekly newsletter at survivingbreastcancer.org. Follow us on Instagram, survivingbreastcancer.org, all one word, and on YouTube at bit.ly/YouTube SBC, and on Twitter, SBC_ORG. If you have a topic idea or would like to be a guest on our show, please contact me at laura@survivingbreastcancer.org. We love hearing from you. Please remember that the content here should not be taken as medical advice. The content here is for informational purposes only, and because each person is so unique, please consult your healthcare professional for any medical questions. Views and opinions expressed in our podcast and website are our own and do not represent that of our workplaces. While we make every effort to ensure that the information we are sharing is accurate, we welcome any comments, suggestions, or corrections. In no way does listening, reading, emailing, or interacting on social media with our content establish a doctor-patient relationship. Thanks. Until next time. Talk to you then.